هذه ما لها شغل. هذه is for me. هذه فقط كذا بس. لا هي مو شغل طلعت. اعملها كذا. اوكي ماشي شكرا. بسم الله الرحمن الرحيم. السلام عليكم. Good evening everybody. بسم الله الرحمن الرحيم. وما أوتيتم من العلم إلا قليلا. On behalf of AstraZeneca, would like to thank all of you coming tonight, late night at the winter time with raining, to join us and to listen to our distinguished speaker with a common subject. Everybody need to touch on this subject, diabetes with a cardiovascular outcome. Vice versa, we'd like to thank also AstraZeneca to make this meeting with the academic gathering, social gathering as well. Many people, we didn't see them for a long time. Then we'll just start by mainly introductory for our meeting, then our colleague will present them later on. This is what you call it dilemma. Shall we call it dilemma? Is it aggressive word we call it, or an issues? I think dilemma maybe is the right word can be used. Diabetes, we are the highest prevalence and even incidence among other countries. Gulf country plus even the MENA, Middle East and North Africa, mainly Egypt. So that means you have more patients coming up, more hyperglycemia. What we have been taught before, if you have bad glycemic control, you will have macrovascular complication like retinopathy, nephropathy, and peripheral neuropathies. But I think last 10 years have been a proof that glycemic control also, if it's not controlled in a proper way, can lead to macrovascular complication, whether in the heart issues, ischemic heart disease, or even heart failure. Definitely our speaker will touch about this point. Second dilemma we have an educational gaps. So nowadays you have more guideline comes up. The ADA, the communist or the famous association, now even they are doing every 6 months their guideline. Now they are collaborating with ESD to have a good real statement. We have ACE guideline, we have a British guideline, Australian guideline. Are these enough? Doesn't look. Since we have more instances of diabetes, more complication of diabetes, whether cardiovascular, macro or macrovascular complication. One more dilemma also, we have more now medication comes up. Now maybe 6 or 7 medication group comes on board. Each group will have like 3 to 4 types. The pathogenesis, are we have real pathogenesis for diabetes or not? What's the indication of this medication? This is also a dilemma. What's the contraindication? What's the side effect? What about post-marketing effect as well? So all these really a dilemma for us as healthcare provider, also for our community. So from AstraZeneca, they have the vision, since they feel that they should be a part of this dilemma, and they put the vision as a starter. Many education programs for healthcare professionals are available, but is it effective? Is it reaching the optimal level? This will be answered by my colleague who will present during their talk. Also, the initiative is designed to improve the care of people with diabetes nationwide through comprehensive, practical, effective methodology. Even this one will be more concise and will be touched during our meeting. So what's the the mission from AstraZeneca point of view, this is what they put it. We trust them to come with us as healthcare provider, also for our strategic plan for diabetes prevention program. I hope they will be in the same line with us. The first mission is to inspire healthcare profession and physician to change behavior and improve patient outcome. Also, they will comprise a series of CME accredited interactive sessions, and also to support continuous improvement care through ongoing education, peer-to-peer learning, and shared experience. Last few years, we hear from them more about this education. Some of them we have seen it on the ground already. Some of them definitely will hear during our this coming 2 lectures. We start by our speaker, first Dr. Afaf Al-Shamri. She's a senior consultant at National Guard Hospital. She's also assistant professor in King Saud University of Health Science. She's active member for National International Society. She's a deputy of our Saudi Endocrine Society, and she was my mentor during my endocrine fellowship before she went to Germany. Okay, so we'd like to welcome Dr. Afaf, and she will touch about heart failure, risk factor, and other element of talks.
Thank you very much, Dr. Mohammed. It's my pleasure to be here tonight, and I would like to thank AstraZeneca for hosting this event. Today we're going to talk about diabetes, but we have to approach it from different aspect, which is the macrovascular complications. Always we ask ourselves, is the diabetes, with all the studies in the past, is the microvascular complications based on UKBDS, which is mainly for type 2 diabetes, and the other thing is for the DCC trial for type 1 diabetes. All of them showed microvascular reduction when we control blood sugar, because we're looking for the blood sugar itself. However, as the macrovascular complication was not neglected, but there was no clear association, that was maybe 1 or 2 decades, is if we control the blood sugar is going to affect the macrovascular complications. When I talk macrovascular, it is the heart and the CNS or the peripheral vessels. So today is the one aspect. Why is not? Oh, okay, sorry. Yeah. How can I move the computer from here? Sorry, can someone help me in this? Okay, so I will talk about the macrovascular complication association with diabetes, and with focusing on heart failure, as the heart failure is the frequent fatal and under-recognized complications associated with diabetic patient. Sorry, yeah, I'll go. How can I just do it? It's not moving. So we will talk about the cardiovascular and diabetes, and the second aspect we will talk about the DECLARE study. So we know the prevalence of diabetes. Everybody knows that is whether in our country or all over the world, global, the diabetes is increasing, and expecting is to be in 25 years from now, as the number will be increased to 629 million will be affected on diabetes. The other thing, which is the most scary aspect, is not following. Sorry. There is a problem with this, sorry. Can you come? Oh, I have to move 2 things, right? It's not going together. Oh, okay, I see. Yeah, but I have to do the sorry about this. The other aspect is the most scary things. The screen is not clear. Is around 30 to 80% of the population, they don't know about they are underdiagnosed or undiagnosed with diabetes. 2/3 of the diabetes and cardiovascular, 2/3 of death and diabetics are attributed to the cardiovascular. 2/3, it's not simple number. It's actually in every hospital, I think, and I'm talking about King Abdulaziz Medical City, around a minimum 2/3, 70 to 80% of a patient coming to the emergency having cardiac problem, MI, or a congestive heart failure, or any cardiovascular problems, they are diabetics. So 2/3 deaths in diabetics, they are having cardiovascular problem. What about is the prevalence is the highest of lifetime risk for cardiovascular of any single factor is diabetes is number one, whether for women or for men. We can see here in the graph, is the screen clear for you? Is it clear? Or we have to raise it up a bit? So here, when we see is the risk of the cardiovascular for diabetics, you can see here is wallah, it's difficult, yeah. Okay, so around 57% developing complications as they are cardiovascular, they are diabetic, compared to 16% on the left side for women without diabetes. And the same for men, almost 2/3 of men is having cardiovascular, they're having diabetes, compared to 30% when they don't have diabetes. Can someone come and help me in this, please? هذا go back. Yes. بس إنه it's not come. Yeah. أنا وصلت هنا no. Yes. Huh? Yeah, but I want to go back. Huh? Wallah? Okay. Bye. I have to do it both together. It's really difficult. It's not convenient. Sorry about this. Because I cannot see here and can't see there. Okay. No. Okay. Okay. So, sorry about this. I'm not getting used to two things at a time, but we go to the. It's going by itself, yeah. Can someone? Hello, is moving without even touching. Can you go back? Sensitive. I have to do it back. Okay, so with the Swedish registry, they just go over the all cause of mortality, and they find they look for the diabetes association with the cardiovascular mortality or cardiac or any cardiac death, as from 1998 to 2014, they found the prevalence of the all-cause death if they are diabetics is more compared to non-diabetics. And the other thing is And when they look at it, the diabetes itself, it doubled the risk of vascular events. Double the risk of vascular, it's macrovascular, whether the heart or the cerebrovascular disease. Compared of the coronary death, it's more on diabetics, and non-fatal myocardial infarction is more as well. And cerebrovascular disease, whether ischemic stroke, hemorrhagic stroke, or unclassified stroke, it's more with diabetics compared with non-diabetics. I think you have to raise it a bit because all the numbers is not clear from the screen down. Huh? Okay. طيب شكرا. It's not working. شلون؟ بلاش لا خلينا احنا ها؟ اوكي. So with REACH registry, the risk increase in diabetes with established cardiovascular disease. When we see the graph here, is the gray one is no diabetes, and with the blue one is diabetes. So the risk is more in diabetics more than non-diabetics. Okay, here. The TIM group studies, the post-MI mortality is higher in diabetics. When we see here in the red one, is the ST segment elevations MI with diabetes, the red one, the first one on the top, is more with diabetics, and the other one is the unstable angina, the black line. So both of them, they are in diabetics, higher than non-diabetics with the dotted graph on the dotted lines on the lower set. So the diabetics are more to develop the complications, and the mortality is higher in diabetics. So what is the pathophysiology? Why do we have the problem with the cardiovascular and diabetics? It's multifactorial, is one of the things is the insulin resistance, and with obesity making the insulin resistance are more, with inflammation, oxidative stress, all of them, they are a risk of atherosclerosis, and with the MACE events. This will cause the cardiac death, and the other thing is the heart failure events is more and can cause death. So all this is affecting the outcome for diabetic patient. Now we focus on heart failure with diabetes, and a main concern here in our speech is the heart failure. What are the complications? When I start my lecture is what is the complications? We know everybody is microvascular complications and the macrovascular complication. The microvascular is the retinopathy, nephropathy, and neuropathy. The macrovascular, myocardial, stroke, peripheral artery disease. And the heart failure. The heart failure is part of the problems that we're having with the diabetes and the complications. In the US national inpatient sample between 1998 to 2014, the hospitalization secondary to heart failure is increased with the diabetics. And you can see this graph is on the top, is whether in men or women, the heart failure admission is so high in the US. The incidence of cardiovascular among insulin-treated patients are more the heart failure. So when we categorize those patients taking insulin type 2 diabetes, the myocardial infarctions is around 97 events in 1,000 patients, and 151 can develop stroke in 1,746 normal patients, and 243 the prevalence of the heart failure. So the heart failure is more in the incidence of type 2 diabetes compared to the other cardiovascular risk, whether the macrovascular, the MI or stroke. What is the recommendations from American Heart Association? They divide the heart failure in 4 stages, A, B, C, and D. The A class is the patient at high risk for heart failure, but they don't have a structural heart disease or symptoms of heart failure. B, structural heart disease, but they don't have signs or symptoms of heart failure. C, they have a structural heart disease with a prior or current heart failure. The D is refractory heart failure requiring specialized intervention. So with the classification, they emphasize the development and the progression of the disease itself. So category A, category B, they are at risk, but they don't develop the complication, whether they are having structural heart disease or they don't have. So what does it mean, this? If we consider the diabetes as a risk factor for the heart failure or developing the developing heart failure, so we should consider those A and B category is to treat them or to interfere early to prevent the complications, to prevent the heart failure in diabetics. So it's A and B. What causing the heart failure is actually when we were in the college, they taught us a diabetic patient, they can have around 40% silent MI when they come. They can see the changes, but the pain or the signs or symptoms, actually the symptoms is less with diabetics. Now what causing the heart failure is more or less the same. They cannot present with the symptoms. Maybe they are asymptomatic, but when they do the echo, they can see diastolic or systolic dysfunction. So with the short wave, those So with the short wave, asymptomatic left ventricular dysfunction detectable in individuals without overt cardiac disease is if they are having diabetes over 5 years, and then they look for the patient is having in around 400 patients, they look for the cardiovascular or by echo and seeing the left ventricular function or the whether systolic or diastolic. So they found 16% they are having diastolic left ventricular dysfunction, 27% is systolic dysfunction, 25% they are having both, and 32%, around third of those patients after diagnosis of diabetes by 5 years, they are having the complication. They are having normal. But 68%, almost 2/3 of those patients, they are having a complication, whether systolic or diastolic. So the heart failure and diabetics, they're one of the most common cardiovascular complications. They are most disabling and deadly complications of diabetes, and very high rate of subclinical heart failure and diastolic dysfunctions in diabetics. The question is effects of anti-hyperglycemic agent. Are those because when we treat the blood sugar, most of the oral or the treatment for lowering the blood sugar does not affect the pathophysiology. Except some of them, it's like TZD group or the big one-eyed group as like metformin, they are affecting the pathophysiology of the disease. Now, when we're considering treating the blood sugar, we have to look after other aspects. Is it positive? Is it having effect on the heart, decreasing the complications of a cardiovascular? Does it have effect on the heart failure or volume overload? So we have to consider these aspects when we treat the blood sugar. The heart failure in diabetics, whether to have a preserved ejection fraction or reduced ejection fraction. So both of them, whether they have the reduced ejection fraction systolic and the preserved ejection fraction is diastolic, both of them can lead to heart failure and hospitalization, be secondary to the heart failure or death. Prevalence of unknown heart failure, whether the preserved or restricted in type 2 diabetes, is increased. You can see the preserved ejection fraction with the pink color and the reduced ejection fraction in the blue color. You can see here is the preserved ejection fraction are more, regardless of the age, starting with 60, 65, or 70, up to more than 80. What does it mean? It means maybe diastolic dysfunction is more with the diabetic patients and they develop heart failure or the complications or deaths related to diabetes. And the in heart failure risk calculator, they consider the diabetes is number 3 risk factor or in the prognosis for the heart failure. Chart program is showed the diabetes angiogenesis, endothelial dysfunction. The other thing is the aggravating risk factor like hypertension or obesity, the other risk factor, and the whether or could be central, CNS activations or resistance to ANP or cardiorenal activation, or the myocardial, which is the glucotoxicity, insulin resistance, lipotoxicity, myocardial fibrosis, ultramyocardial energetics. So all this can cause the heart failure on diabetic patient. The other one is the diabetes affect both the bump and plumbing. What does it mean? The bump is the مضخة أو الأنابيب نفسها. فit's affecting both of them. Both is the bump, المضخة اللي هي الheart, could cause heart failure or could have major cardiac events or could cause mortality. So both of them is affecting, the diabetes is affecting both of them, the heart with the ejection fraction systolic or diastolic, or affecting coronary artery disease. This will precipitate the complications for diabetes. I'm gonna skip this. I'm gonna skip this. So the core take messages here on the diabetes leads to malignant cardiovascular phenotypes, and the cardiovascular events in diabetics, macrovascular, microvascular, heart failure. And the other thing, prevention and treatment for both atherosclerosis event and heart failure, important to reduce cardiovascular death. Diabetes with the macrovascular and heart failure can cause the death, so it has to be looked after and considering when you treat patients with the diabetes. I have to skip the slides to go to the declare. So declare, just to touch for a few slides with the declare, what is the concept of the declare study? The declare has been released last year with the SGL2 inhibitor for a primary and secondary prevention of cardiovascular and renal outcome in type 2 diabetes. It's systemic review and meta-analysis of cardiovascular outcome trial. The declare is actually one of the largest study, is involved more than 17,000 patients, and they choose patients with diabetes more than 40 years, and they are having multiple risk factor or established cardiovascular disease. And they divide them in two arms. One arm, they're using dapagliflozin, which is the Forxiga 10 milligram, and the other one is a placebo. But they standardize the other oral hypoglycemic agent. And those patients, they look for the primary endpoint and secondary endpoint. The primary endpoint for those patients are mainly for the cardiovascular. And the secondary is taking renal and other risk factor. And the other thing is to look for efficacy and the safety for both arms and to compare together. The demographic and baseline characteristics of those patients, they are equal on both sides, almost. The average age is 63, and they're almost 2/3 of them males, and one-third are female, and the race is the majority are white, around 80%. And the other thing is mean hemoglobin A1C is equal in both arms, around 8.2, and the median duration of type 2 diabetes around 10 to 11 years, and the BMI is equal in both arms, around 33, so they're obese, more than 30, and the mean systolic pressure, they are equal with the normal range in both arms, and the mean GFR normal for both arms. I'm gonna skip this. The other one is the look for the choose from this category with the out of the 17,000, 10,000 of them, they're having multiple risk factors for cardiovascular disease. And there is around 5,000 patients, they are having atherosclerosis cardiovascular. So they divide them in two groups and they compared with them the hemoglobin A1C and the LDL and other factors. I will go with the conclusions or the to see on both category those the heart failure is actually more with the patient is having established cardiovascular disease. Okay, with multiple risk factor they are less, which is the almost the 2/3 of those patients. They are looking for the results, and they can see and the effect on MACE with the major cardiovascular events as the DABA is effective, but there is no big difference too. But what makes the things is the striking is the heart failure is less with the group with the using the dapagliflozin. I'm gonna skip some of the slides. For the sake of the time, I'm sorry, but I have to skip and go for the endpoints. So the endpoints, okay, here is the endpoints and component, as you can see, the heart failure, hospitalization for heart failure is in favor. When it comes to the left arm or the left side, it's in favor of dapagliflozin. Myocardial infarction is in favor, but there is no big difference. And ischemic stroke is non-significant, and cardiovascular death is non-significant. Non-cardiovascular death is in favor of dapagliflozin. I'm going to skip these slides. Okay, thank you very much. Is there any question? Because I have to leave. Or you can leave it for Dr. Walid Al-Habib. He's the cardiologist is interested in congestive heart failure. So he's like the pioneer in this field. Okay, Dr. Mohammed, you're going to introduce Dr. Walid. Okay, thank you very much.
Thank you, Dr. Afaf. I know she got social issue. She have to leave early. So our next speaker is not appearing. I think most of you know Dr. Walid Al-Habib. He's a cardiologist. He's an active member for More Society. He's the president of Heart Failure Workshop. He worked initially in King Faisal, then he was shifted to King Khalid University Hospital. He's also assigned for many guidelines. He's supportive. He likes to give talk. We are lucky to have him many times in military hospital, also in Prince Sultan Cardiac Center. I think he will continue what Dr. Afaf she stopped, and we can utilize him according to Dr. Afaf. All the question should be shifted to him at the end of his talk. تفضل عليك.
Thank you very much, and thank you for having me. It's time for the cardiologist to take over, I believe. We are taking over diabetes management as well, so we will take over the stage. May I start by asking how many cardiologists are here? Any cardiologists? None? Zero cardiologists. Oh, very interesting. Although I've said we're taking over, we're managing diabetes now, but maybe they know it very well. Internists, how many internists? Okay, endocrinologists? The others are physicians? What else? Primary care? Primary care? Okay. ER? Emergency? Okay. Nice. Any nursing or pharmacists? Pharmacists. I know a table of pharmacists. Yeah, the whole company is a pharmacist. AstraZeneca, the whole thing. Okay. So now establishing by Dr. Afaf how cardiovascular disease is a major outcome of diabetes, and heart failure specifically being under-recognized is a true word. And many of you can attest how heart failure in the past decades wasn't taken care of specifically by any interested personnel. The cardiologists will refuse seeing them, sending them to the internist will send them to the pulmonologist will send them back to the emergency room, and the patient unfortunately just gets lost. Thank God there are people now more interested in heart failure, and there's a subspecialty in cardiology called heart failure, which I specialize in. And that would take me to discussing a little bit about heart failure, the pandemic of heart failure, the burden of heart failure, and some data about it in our region in Saudi Arabia and how we can touch it. And hopefully, I know it's me between you and the dinner, but inshallah, I won't take too long. Now, heart failure worldwide is, as we said, under-recognized, underestimated. We don't know exactly how many people in the world have it. I'm pretty sure this is an underestimation. There are reports of up to 26 million people probably worldwide affected. It's about 1 to 2% of any population. So in Saudi Arabia alone, we expect like 500,000 people having heart failure. And the reason is very obvious. One of them is the previous talk, the increased risk factors. Many people now are having more diabetes, hypertension, hyperlipidemia, obesity, smoking. All these just eventually lead to cardiovascular disease and heart failure. So we're having more and more. Another important factor is aging. We are doing a good job, and this is actually one of our targets, is to increase the longevity of people. Instead of dying in their 60s, we want them to live to their 80s, but they end up with heart failure as well. A third reason, very interesting, is that we as cardiologists are doing a very great job in saving people with MIs. Myocardial infarctions in the past, if you get one, you're probably dead if you don't get to the hospital in time. And even if you get to the hospital in time, probably I'm pretty sure some of you would remember in the old days, all what they used to do is just bed rest and nothing. Now, interventions, medications, we save patients, but with a weak heart and heart failure. So we're seeing more and more heart failure. Now, heart failure is not just increasing in number, it's very costly, and you can all attest to that. The main reason of cost, and I'll show you, now this is just a record in the US. It costs right now more than $30 billion to take care annually, $1 billion annually to take care of patients with heart failure. And it's projected to increase and double with time. And the main cost is driven by hospitalization. These patients recurrently come to the emergency room, recurrently come when admitted because of decompensated heart failure. And although we think about medications and treatments and physicians, and it doesn't mean a lot. The drugs, the physician provider, of course, one aspect that we don't think about a lot is low productivity or loss of job time and days when you are sick, and that by itself is very costly. Now, besides the cost, I know I started with the cost because everyone is thinking about money nowadays, and we're just trying to constrain expenses, but the biggest burden of heart failure, as I said, is in the morbidity and mortality. The morbidity is mainly in readmissions and hospitalizations and loss of activity, but the mortality, 50% of your heart failure population is expected to die within 5 years. So if you have 100 patients in your clinic right now with heart failure, within 5 years you expect half of them not to be there anymore. 25%, 1 in 4 will die within 1 year. And that depends a lot on the stage of the disease. Those with advanced disease, those with very severe disease have a 50% 1-year mortality. So the heart failure is truly sad, and I'll show you in a while how bad this mortality is compared to cancers. The hospitalization, as I said, is very frequent. 25% of the patients discharged are expected to be back in the hospital within 1 month. And what is unique about it is that these patients just continue progressing. Continue progressing. Every time they get a decompensation, they never go back to their baseline. It's like it eats a chunk of their heart. So every time they decompensate, every time they get admitted, they just go down further until they die. And this mortality that I'm talking about, 50% in 5 years, is worse than most of the cancers that we know. It's worse than leukemias and colon and rectal cancers. It's probably only short of just lung cancer. And it's truly said heart failure is more malignant than cancer because of the bad outcomes. Again, the severity of this disease dictates that. A very simple way of addressing how bad your disease, the heart failure is, a simple model that we took in medical school, the New York Heart Association classification. You just ask your patient about the shortness of breath with the exertion. How much can they walk, or how far can they go without getting short of breath? And we know that the patients who are even short of breath at rest or minimal exertion, that we call class 3 and 4, have the worst outcome, have the worst increased mortality and hospitalization compared to those with New York Heart Association class 1 and 2. Even class 1 and 2, although 1, by the way, is supposed to be totally asymptomatic, probably like a normal person, still has a worse prognosis compared to the general population, but not as bad as class 3 and 4. And so the quality of life of these patients is definitely devastating, and it's very similar to those on dialysis. And you know how bad the quality of life of dialysis patients are, having to come to the hospital probably 3 times a week to get dialyzed. I like to show this graph because when we look at patients with heart failure, if we don't catch them soon enough, they just succumb fast. And it might be too late. Many of us try to interfere or intervene with the patients when they become really sick, when they're very short of breath, when they're really recurrently hospitalized and coming to the hospital. That's probably too late. I'm not saying don't do it, but that's probably too late for the patient. The best timing is when the patient is either discovered asymptomatically with LV dysfunction or has the minimal symptoms that you could intervene with. Now, just a few data about our local population. We did the Hearts Registry, you probably heard about, and it was published. We did 2 parts, the acute heart failure and the chronic heart failure registry, and it gave us a glimpse about what's going on in our population. Yes, we might not be totally different than the West, but we do have unique features compared to the West. Now, the most common cause of heart failure worldwide and in our population is coronary artery disease. So myocardial infarction, just eating the heart muscle, causing a weak muscle and heart failure. Dilated cardiomyopathy, idiopathic or non-ischemic dilated cardiomyopathy is the second probably, and this is in the acute registry. Hypertension is very common cause of heart failure, is the third. Valvular heart disease, interestingly, now is not a very major cause of heart failure, although we used to have a lot of rheumatic heart disease. It's being treated well and not causing heart failure these days. Now, as you can see, diabetes hasn't been, these are all the authors or the researchers' choices. Diabetes, until recently, is not considered as an etiology per se, although we know by now that there is an entity called diabetic cardiomyopathy, and diabetes causes it for sure. But most of the time we thought that it was because of coronary artery disease, because of vascular disease. But we know by now that it's not only that. This was published in 2011, by the way. But looking at risk factors, these patients had comorbidities, had risk factors probably for that. And as you can see, 70% of these patients had hypertension. 64% of the heart failure patients had diabetes. And that's why I always joke with my colleague endocrinologist, say, I manage more diabetes than you do, because more than 60% of my patients in the clinic are diabetic. And I see them probably more often and deal with their diabetes. Many of them are dyslipidemic. Of course, this is probably underrepresentation. People don't always admit that they take alcohol. Exacerbating factors, which is a very important thing. Now, people, as I said, decompensate. There are many reasons for decompensation. Part of it is the disease course itself. It worsens, they decompensate, they come to the hospital. But a big part of it, unfortunately, in our population, which is unique, is non-compliance. Non-compliance, non-adherence to recommendations, lifestyle recommendations, or medications, and fluid and salt intake is really a big issue in our population. You know that. Patients come, you give them 3-4 medications, they take only 2. You tell them do this, they don't do it. There are lots of perceptions, and working on this, I'm saying this because this is a target that we need to work on, improving compliance of patients to their regimen so they don't decompensate and worsen their heart failure. Of course, other reasons of decompensation, as usual, are infarction, myocardial infarction, or ischemia, arrhythmias. Infections is a very common cause as well. Now, just a comparison between Saudi Arabia and other places in the world. This is the ADHERE in the USA and Optimize in Japan. I just wanted to point out that the age is much younger in Saudi, 61 versus 70s in the rest of the world. So we're at least 10 years younger in the onset and the disease And this is probably one of the reasons why our longevity is less than them. But also, if you look at diabetes, the world is about 30s to 40s, we are 60s. 60% of the heart failure population is diabetic. So it is a big issue that we deal with. The mortality recorded in our registry was about 6.5% in hospital, 8.3% 1 month, up to 13% in 6 months, and up to 24% in 3 years if you got an admission with heart failure. Then we looked at the chronic, that was the acute decompensated heart failure, patients who were admitted with acute heart failure. We also looked at patients in the chronic heart failure state, those who had chronic heart failure following the clinic, not hospitalized, and we found that in those population, we have more non-ischemic cardiomyopathies, dilated cardiomyopathies, and although there might be a genetic background to it, I think that we have a lot of younger population of patients using street drugs. Probably heard of Captagon, and in addition to alcohol and other things, many of our kids are taking these things and they end up with cardiomyopathy. So we are having more non-ischemic or dilated cardiomyopathies probably compared to others. Ischemic heart disease is still there and still the highest, but it's less. Hypertensive heart disease, about 10%. And I always stress on treating hypertension very well, otherwise you end up with heart failure. Don't have to show this, but I want to show you that in this chronic population as well, the 3-year mortality was 24%, but the readmission rate was about 37% in 1 year. That's a big. So you about more than 1/3 of your patients will be re-hospitalized again, and that's very important. And the Gulf, for the sake of time, the Gulf registry looked at the whole 7 Gulf countries. Although Saudi Arabia is still the biggest part of it, it showed very similar data to the Saudi to the hearts registry in Saudi Arabia. So I'm just going to go through it. It's published as well, and you can track it. Now, I talked about heart failure, and we always say heart failure, but I think it's very important to stress on what is heart failure. How many of you deal routinely with heart failure patients? Internists, I'm pretty sure. ER physicians, I'm pretty sure. Yeah? So now, it's nice to define heart failure because we usually depend on echo to say that this patient has heart failure. And I want to stress on the importance of the word here. This is the definition of the European Society of Cardiology, American College of Cardiology. It's a clinical syndrome. Clinical syndrome. By clinical, we mean bedside. Sariri in Arabic. So it's your clinical findings of heart failure. Signs and symptoms of heart failure. The classic signs and symptoms that we know: shortness of breath on exertion, orthopnea, PND, fatigue, high JVP, lower limb edema, crackles. These are the classic signs and symptoms of heart failure. This is when you say, I have a heart failure patient, regardless of the echo findings that we're going to talk about. And the reason I'm going to talk about it is because there has been some changes in nomenclature, and it's very important treatment. Now, classically in the past, we always, and we still use sometimes, systolic and diastolic dysfunction. It's easy to understand. You just believe that it's systole that is a problem, it's not contracting well, or diastole is a problem, it's not relaxing well, but it's a little bit more complicated than that. If you want to keep it this simple, it's fine. We use now for the word systolic dysfunction or systolic heart failure the word reduced heart failure with reduced ejection fraction, HFrEF. And for diastolic heart failure, we use the word HFpEF, heart failure with preserved ejection fraction, because the ejection fraction looks okay. Now, by reduced, we mean less than 40%. Preserved, we mean more than 50%. Unfortunately, that keeps us with another range in between the 40 and 50. Why did we divide it this way? Because most of the drugs that we know, most of the medications that we use, ACE inhibitors, beta blockers, mineralocorticoids, all of them has worked in the reduced ejection fraction. They worked with systolic dysfunction or ejection fraction less than 40%. Unfortunately, not much or nothing has worked in the preserved ejection fraction. We don't have many medications there. That's why we divided. Now, 40 to 50 is there because not many studies have been done for this population. So we don't even know if it's going to work or not work. Okay? So less than 40 is reduced, more than 50 is preserved, and in between there's a 40 to 49. Now, there's a long talk about this. You can call it mid-range, as the Europeans. You can call it borderline, as the Americans. We believe that medications that work for reduced might work for mid-range from post-hoc analysis of studies. Now, Dr. Afaf showed you this slide in a different way. I just want to touch on it for a reason, is that when we stage heart failure, we say clinical heart failure. That is usually stage C. Those who have the signs and symptoms of heart failure, those are the ones we know that these medications will work with. But there are two stages before that which are very important for prevention. So stage A, those who just have risk factors. And as we agreed, diabetes, hypertension, obesity, metabolic syndrome, these are all risk factors for heart failure, and it's our role as clinicians to prevent these patients from proceeding to heart failure. If you don't treat these, they will end up with heart failure. And that's why they classified them as a heart failure. Stage B, they developed a structural heart disease. They had an MI. They had a left ventricular hypertrophy. They had something in the heart, but they never developed heart failure. These also need the focus so they don't progress to heart failure. How many of you routinely order BNPs or natriuretic peptides? ER, definitely. Yeah, internists, you don't order BNP? I might change your mind now. Now, natriuretic peptides, which are whether a BNP or an ANP, when we say BNP, it's called brain natriuretic peptide, but it's actually coming from the ventricle, the left ventricle, or the right ventricle. The main stimulus is stretch. So more volume in the body, the more the ventricle stretches, the more BNP you get, means that you're in heart failure. Okay? There's an ANP also, which comes from the atrium, but it's not commercially widely used. We depend more on BNP or NT-proBNP. Now, if you have a very high proBNP, that means heart failure. Okay? If you have a very low BNP, it means that there is no heart failure. But the question is, what if I have? We agreed that heart failure is a clinical syndrome. So you might still have some BNP, high BNP, or in the moderate range, but you're not actually in heart failure yet. What does that mean? That means that you will develop heart failure. Now, kullu biyadillah, but this is what the studies have shown, that many patients who had developed heart failure had a high BNP even 6 months earlier. And that's why the recommendations is even at patients at risk for heart failure, it's a class 2A here, class 2A. If you're at risk only, just have high-risk features, diabetes, hypertension, obesity, A 2A means it's reasonable to be done. It might be beneficial to check your patient at high risk for heart failure. If he has a high NT-proBNP, then you can work on doing something for that patient. Okay? Now, definitely green means 1. It's a class 1 indication. It's a must in those who already have developed heart failure, mainly for diagnosis, and one important thing for prognosis. If you have a patient with heart failure and his proBNP or BNP does not go down, then this patient has a very bad prognosis and should be addressed more specifically and more intensely. How to diagnose heart failure? There's an algorithm, very simple algorithm. I go back to the point of clinical. It's a clinical history physical examination, and then the next step is an NT-proBNP. After that, you can go for an echo. If you have a high NT-proBNP, you can just go for an echo to confirm whether it's reduced or preserved ejection fraction. Now, I'm going to show you this, and just going to touch briefly on the management because of the sake of time. But I want you to understand the concept of if I have heart failure, which is the basic reduced cardiac output from the heart, that means the rest of the body is not seeing enough blood. It has to react. It has to react. The rest of the body is reacting إذا تداعى له عضو إذا اشتكى له عضو تداعى له باقي الأعضاء بالسهر والحمى. The rest of the body is trying to compensate. How is the sympathetic trunk going to compensate? It's going to secrete more epinephrines, adrenalines, noradrenalines. The kidney is going to compensate by retaining fluids. The body is smart, but probably not smart enough. It doesn't understand that a low flow does not, or a low pressure does not actually low fluids. The only way it can compensate is just increasing fluids. You know, when you go to a hospital and you're hypotensive, the first reaction people do is give IV fluids. The patient might be in heart failure, but because they want the blood pressure to go up, they just give IV fluids. It worsens the condition. But that's the way it's compensating. The periphery is just vasoconstrict. It's trying to improve the flow by vasoconstricting, but the more vasoconstriction it does, the more blood it cuts off. So what is our job as clinicians is to reverse these actions. This is what we do. We reverse this vasoconstriction by giving vasodilators. We reverse this fluid retention by giving diuretics. We reverse this sympathetic trunk overflow by giving beta blockers. Okay? Now, the one thing, of course, vasodilators are like angiotensin receptor and ACE inhibitors, angiotensin receptor blockers, and beta blockers, as we said, for sympathetic overflow, hydralazine nitrates as vasodilators as well. Now, but mineralocorticoid antagonists. What I didn't mention about natriuretic peptides is that it's secreted because of stretch, but what does it do? It's called natriuretic peptide. So it causes natriuresis, and what follows the sodium, natriuresis is sodium, what follows the sodium is fluid. And it causes some vasodilation. Unfortunately, in the body, we have an enzyme called neprilysin that inhibits natriuretic peptides. So if we can inhibit this enzyme or break down this enzyme, we might get more natriuretic peptides that can work more, and this is neprilysin inhibitor. And you probably heard about the ARNI, the angiotensin receptor neprilysin inhibitor, sacubitril valsartan, which was studied in the PARADIGM trial and showed significant outcome improvement when used. So, and for the sake of time, I won't go through this, but I want to stress on an important algorithm in managing your patients. Any patient with reduced ejection fraction should be on ACE inhibitor, or an ARB, or an ARNI, plus a beta blocker. That's a must. Has to be, any patient with reduced ejection fraction has to be on one of these three plus a beta blocker. The next step, if the patient is still symptomatic, you might add aldosterone antagonist. Okay? Now, the European guidelines says that you start with ACE and ARBs. ARNIs, which you probably know, Entresto, should be used if you fail ACE inhibitors. You also probably heard about ivabradine, which slows your heart rate because of the importance of heart rate. Now, there are other ways of managing heart failure as well, including devices, which I, for the sake of time, I won't go through, but these are cardiac resynchronization devices that help the ventricles contracting. And you know that SGLT2 inhibitors cause glucosuria as well. And just one word on advanced heart failure. You remember when we said that there's stage A, B, C, and D? D is the advanced heart failure, which used to be called refractory heart failure. But I don't like using refractory because we can still do something. Those who are on maximum medical therapy, still symptomatic, the best option for them is? The best option for them is heart transplantation. Okay? Now, if you don't have heart transplant or you have a long waiting list, before that you can do an assist device or an artificial heart that helps take the blood and pumping it back to the body before you go for transplant. Actually, some people are living on this for years now and not requiring transplantation. So with this, I would end. Thank you very much.
السلام عليكم. People they are leaving, or we can ask some question. Who's so? Dr. Walid, any update about SGLT2 and heart failure? Do you have any published, unpublished, what to call it?
I was asked not to talk about it.
Okay.
Specifically. They're actively okay? So I did have slides and they were removed. Recently, you probably heard about the DAPA-HF trial, which dapagliflozin was on top of optimal medical therapy, showed significant reduction in mortality and heart failure hospitalization. And it was a very, very positive study, and we are waiting for the FDA approval for using it. But dapagliflozin specifically now studied in the DAPA-HF was positive in heart failure with reduced ejection fraction.
Is it published?
Published. It was already published.
Already.
Yeah, it was already published. It was already published in the New England Journal of Medicine in September. In September, yeah. So it's already there. And it was a 4,000 patient study. It was a good study.
Yeah, thank you for coming up. I think dinner is ready. Okay.
دقيقة.